I'm Jeff Jefferson, formerly known as James Jefferson, Clinical Professor of Psychiatry at the University of Wisconsin Medical School in Madison, Wisconsin. And what I cover today is the whole topic of post-traumatic stress disorder, which I have to say is very difficult to fit into a 45-minute presentation. I want to give you several perspectives of this pretty diverse problem. The first one is we have a nice set of definitional criteria known as DSM-4. Everybody knows DSM-4. What everyone doesn't know is that DSM-5 is on the horizon. It's supposed to be out in 2013, and there is talk about rather major revisions in what is post-traumatic stress disorder. Now, I said in my presentation today that this is such a complex area. I'm not prepared to tell you what the changes are going to be because they're not finalized. But my sense was that trying to understand all of this almost caused me to have post-traumatic stress disorder. So the ground rules change. The basic issue is a very severe trauma and a response that's pretty much overwhelming emotionally. It can occur acutely, it can be persistently chronic, or actually can have a delayed onset. So it may be 6 months or more after the trauma before the symptoms take over a person's life. This is not a new condition. This is not a new condition. The first really written concepts in the US at least go back to the Civil War. And the focus then was always on war. Civil War, World War I, World War II. Now we're seeing an enormous number of soldiers from Iraq and Afghanistan exposed to massive trauma and a very high incidence of PTSD. So that's another point I want to make is how much PTSD is out there depends on where the population comes from. So one of the issues, of course, is if you're living a nice, mild, happy life like I do in Madison, Wisconsin, the traumas I'm exposed to so far, minor, low risk. There's another aspect, though, of PTSD, and that is there may be a genetic vulnerability to developing it. And basically, let me summarize that fairly quickly. You have the right two genes in a certain area, and anything bad that happens to you bounces off. I mean, you're not happy about it, but you don't fall apart, you don't develop PTSD. If you have a different genetic makeup, you may be very vulnerable to developing PTSD. And this probably explains why, despite being exposed to absolutely the same traumas, that only some people develop this condition. There's also some neuroanatomy observations that suggest that certain changes in brain structure may actually predispose people to this condition. So that's a bit of the background. Now what about treatment? I mean, we talk about treatment of these conditions. We always divide them into pharmacotherapy and psychotherapy. And I think anybody who's sane would say combinations of the two probably are the best approaches, although this is surprisingly understudied in any kind of formal way. Now, if you believe the FDA in what's approved for the treatment of PTSD, there are only 2 drugs. These are SSRIs, 2 drugs approved. I'm firmly convinced that everything in the serotonergic category will have a beneficial effect. I can't prove that. That would be off-label, of course. We're not supposed to talk off-label. But SNRIs, SSRIs appear to be the drugs of choice. Now that's easy. And if all there was to it would be go on one of these medications, get the right dose, get the right duration, and then you'll live happily ever after. The problem is if you sit down and review the data that got these drugs approved, you'll find out that they are far from perfect. So now the question comes up is, if one drug doesn't work, what do you do next? And everybody now will do a switch within the category, SSRI to SSRI, there's no evidence that that cannot be effective, or SSRI to SNRI, and then there's the other issue of how do you treat it pharmacologically, and most people would approach it in terms of, is there a partial response? Then let's add something. Is there absolutely no response? Let's switch drugs. Now, how much data is there to support those two directions? Very little, unfortunately, but that's what most artful clinicians will do. Now, in this day and age, we always have the issue of atypical antipsychotics. Strangely enough, they are understudied in this condition, and they really haven't been proven to be a cure-all as an adjunctive therapy. Now, before I finish, I want to put a big, strong plug into a cognitive behavioral therapy approach, which is very well established as effective in those populations who can engage in the treatment and who are treated by qualified therapists. Now, I said that because it's quite important to know that this limits the population available for this type of effective treatment. Basically, the concept is exposure, and again, exposure means in a safe situation type exposure, and it can be in vitro, in vivo. There's some imaging processes that can expose people in a very safe environment. And again, if one is exposed long enough and repeatedly enough, generally what happens is these symptoms decrease, become more tolerable. And the good news about CBT that's successful is the benefits persist considerably longer than the benefits of medication once medication is discontinued. I like to believe, as I said earlier, combination therapy has got to be the way to go.